Hello friends, greetings for the 2018 to all my listeners and channel subscribers. Today I wish to inform you about my 2017 work which we performed in my unit about the heart surgeries. It has been a very eventful year in 2017. Lot of work which was referred to us about coronary artery bypass surgeries. We did a lot of heart wall replacements, heart wall repairs, aneurysms, and many other such heart procedures. It has been not only eventful year, we also performed many complicated cases or with cases with complexities. Like we had cases where heart function was less than 20%, poor heart function, what you call. We had cases with acute entraval MI, and we had to operate upon within first 3 days, where patient was thrombolized and the patient was continues to have unstable anginas. Like that, there are many such categories which I can inform, we can discuss, and I can give you details about it. Let's start with the cases which I started with the last year. The case of patient who had a very poor heart function of less than 20%. Apart from that, he had severe pulmonary hypertension. The PA pressure was 65, and although PET CT scan showed myocardial viability, so we took up the case and we performed the coronary bypass surgery in these cases with the use of intra-aortic balloon pump, and it worked out very well. And the balloon pump was removed within the next 2 days, and the small inotropic support, and his heart function improved after heart surgery to 28%. That shows that the right kind of reverse these patients can be rewarding. Second category which I want to inform you about the cases where person is having acute AMI and has been thrombolized or not thrombolized but continue to have chest pain. Angiography shows if it is a non-ST elevation, I have to give him the proper revascularization. Although hemodynamically they are, so we use all the methods all protocols to maintain hemodynamic stability and perform. These cases are tricky, lot of arrhythmias occur, but if we have proper protocols and control arrhythmias and do proper revascularization, these patients can give very satisfactory results. Third category which I want to discuss is the cases which we have been referred to this year is the cases of kidney failure, renal failure, when patients can either creatinine is higher than 2 milligram percent, or patient is on dialysis. Almost 2 dozen such cases have been referred to us last year, and where coronary bypass surgery was advised in view that patient may require renal transplantation or may continue to be on dialysis. And these cases are also little bit difficult to handle because of their kidney functions, poor kidney functions. We usually opt for on-pump coronary bypass surgery in these cases, where during pump we do use of dialyzer, so that the kidneys load is reduced tremendously and creatinine remains within acceptable limits. And the fluid management is also very easy to when we use dialyzer, and electrolyte imbalance doesn't occur. And with these kind of protocols, I could give 100% success in such cases of renal failure requiring coronary bypass surgery. Third category which I want to discuss is the cases with very poor lung functions, COPDs, chronic airway obstructive disease, asthma, or any other reason like interstitial lung disease, but continue to have unstable angina, and they've been advised coronary bypass surgery. Previously, these cases were not accepted for surgery, but we do get these cases, half a dozen cases of such nature. We operated last year along with the help of a pulmonary physician who optimized lung function before allowing these cases to undergo surgery. My protocol in these cases is to use intravenous anesthesia, not to use any gaseous anesthesia, so that lung functions are maintained, alveolar membrane is intact, and gaseous exchange is adequate. And I usually extubate these cases as early as possible, not using too much of steroids in these cases, and do as much as possible the global revascularization. Again, these cases have been done very successfully, full year, and they have been doing well. Fourth category which I want to discuss today is the cases which have been now in rise, that the cases where stenting has been done in multiple vessels, and these stents are getting blocked within 3 or 4 months. Many such cases have come to us, and the numbers are rising. In triple vessel disease, advised are they have been stented. PTCA was done within 3-4 months. As you know, the stents have the blockage rate of 10% per year per stent, and when the multiple stenting has been done, either patient is not compliant, not taking drugs or antiplatelet agents properly, or inherent nature of stenosis in these stents are the cause where they get blocked, and then they are referred for surgery. Such cases have been on rise, and we have to do lot of endarterectomies in these cases where long length of stents have been deployed in coronary arteries. I will advise that it is important for all of you, and especially doctors, those who refer these cases to cardiologists, that although stent price is down, but it doesn't mean that the international protocol of using stents versus coronary bypass surgery should be forgotten. You all know that the Syntex trial has shown very clearly that multiple stenting is no good, and coronary bypass surgery has a better long-term result and rewarding, and with less and less hospitalization after surgery. So it is important that triple vessel disease or left main stem disease should be referred to surgeon so that they can do a proper job, and patients can get long-term relief of his symptoms. Then we had some interesting cases of left ventricular aneurysms. Left ventricular aneurysm along with coronary bypass surgery. Left ventricular aneurysm is a chronic complication of a coronary artery disease after myocardial infarction. We did 6 such cases last year where LV aneurysm was in 3 cases left ventricular aneurysm was anterior placed, and in another 3 cases lateral, and 1 was inferior wall aneurysm. Some of the cases required aneurysmectomy because of the presence of clot in the left ventricular aneurysm sac, and some 3 cases we did aneurysmal repair along with the coronary bypass surgery. These cases are also rewarding, and although they are sick cases because of poor heart function, but once you remove the aneurysmal sac, the dead area of the left ventricle goes away. The left ventricular remodeling can be achieved with greater ejection fraction and better hemodynamics, and these patients can have good normal life with some kind of medication continuing for the life. Then we did some cases of interesting cases of cardiac tumors. I did 2 such cases of myxomas, the left atrial myxoma and right atrial myxoma. One of the ladies came from Africa who was diagnosed to have a tumor on the MRI of the cardiac MRI, and although she came for a heart checkup for the routine low degree of fever, she was investigated. Echo showed a mass in the left atrium. Then she underwent MRI, cardiac MRI, which suggested that she has a myxoma. She underwent successful myxoma surgery, and it is such a rewarding surgery in these cardiac tumors that once the tumor is out, patient is treated of his cause of his ailments. So I would like to inform you that any such long-lasting low-grade fever or some kind of numbness or some kind of stroke, you should keep in mind that there can be possibility of a tumor in the heart. And these are, once they are referred to and they are operated upon, the results can be just rewarding. Some more cases, complicated cases we did, like we did a case of multiple procedures, double wall replacement along with the 5 grafts of the coronary artery disease. As an old lady, above 70 years, her one aortic stenosis and mitral stenosis was there along with the severe triple vessel disease. Such case complex procedures have been done very regularly now with either aortic valve replacement and coronary bypass surgery, or mitral valve replacement or mitral valve repair with ischemic mitral valve disease along with the coronary artery bypass surgery. And these complex cases are also usually are done on pump, and we have rewarding results in these cases. Although the trend is now to use tissue valves, but in case tissue valve doesn't go in, then we have to use metallic mechanical valve, and they can be managed very well with anticoagulation in these cases. New trends have come. Last year we did some TAVI procedures in aortic stenosis cases, and some more such left heart devices are available now, and we have been using them in a good number of cases where it is required. So friends, this was a very eventful year. We did a lot of heart surgeries of complex cases along with the elective coronary bypass surgeries, and the success rate has been maintained above 99% even in complex cases because of our strict protocols, preparing the patient properly, and at the same time giving them full benefit of the latest protocols and latest treatment methodologies. And I hope that once you know that these cases are done now on a regular basis, and you also know that surgical treatment is also available to you, it is important for you to know that surgical results, when they're required, should be referred to heart surgeon, and they can do wonderful job in these heart surgery cases. Thank you very much, and I wish that very good luck for the next few years, next 2018, and hope that heart surgeries are referred in a proper manner. Thank you very much. ज़्यादा बोला.
मिनट 12.5 मिनट.
अच्छा हुआ. अपलोड हो रहा है अभी
फेसबुक में?
नहीं, यूट्यूब पे.
फेसबुक पे शेयर कर दिया.
क्यों शेयर कर रही है अभी तू? I want to redo that on Facebook separate. Just upload on YouTube on my channel.
आपने कुछ किया है इधर?
एंड रिकॉर्डिंग किया ना तुमने?